Cool. Well, maybe we'll get the party started. Happy May. Thank you all for joining us for our May task force meeting. I'm sure many people are enjoying spring in Colorado and graduations, and it's just a good time of the year. Couple quick announcements that are also in the timely task force updates, and we'll put them in the chat. There's the event in Pueblo for GYN cancer survivors on May 20th. Deadline for interest in the advisory committee is June 2nd, so please check your email. And then we're having Survivor Day in Colorado Springs on June 7th. And if you're interested in working with the cancer plan, there's an event on June 9th. And then we're going to press pause in the month of July, but we'll definitely see you back in September and we'll talk about alcohol awareness and the effects of alcohol on health and cancer. So, without further ado, it's my pleasure to introduce Dr. Ben Brewer and Dr. Erin Baurle. They are colleagues of mine, and I will let them introduce themselves and their topic, and um, maybe they have some suggestions for our patients and for ourselves. Thank you, Ben and Erin.
Yeah, thanks so much, Carlin. So Erin, don't let me speak for you. I'll actually share the slides in just a second, but why don't we do quick introductions so you guys know who we are and where we work and all of that. I guess I can go first. I'm Ben Brewer. I'm a psychologist. I'm embedded in our hematology division on the Anschutz Medical Campus. And we treat obviously blood cancers, leukemia, lymphoma, multiple myeloma, and a bunch of other ones that are harder to pronounce. And then we also do cellular therapies, so auto and allo transplants, but also CAR Ts for the whole campus, so including things that aren't cancer. And so that's where I work. I'm an expert at behavioral sleep medicine and have done research and a lot of public health work, kind of in bringing basic sleep medicine to people that really need it but don't have access to it, is sort of the goal. And Erin, go ahead.
Great. Hi. Thank you for having us here today. I'm Erin Baurle. I'm a psychologist as well. I live in the Department of Medical Oncology, so I oversee a team that helps with the psychosocial aspects of solid tumor cancer here in the Denver metro area. Ben and I also partner on a training program in psychosocial oncology, and in the last 2 years, and hopefully moving into year three, have been working on improving sleep for cancer patients and education for providers across the state, which is what we are here to talk about today.
I'm going to quickly share the slides. I made a couple of I just reordered one thing, Erin, if that's okay. Um, okay, can you all, let me make this proper. Hold on. Now, do you all see the presenter screen or the full slide, full screen?
We can see it, and then you can see the little slides on the bottom.
Okay. Let's do that. Let me see if I can make it a little better, actually. Give me 1 second. Well, it doesn't like me today. Let's see if I can just share it again. Okay. Okay, we'll go with that.
Looks good.
Do you want to start, Aaron?
Oh, sure. So we are here to talk to you all. We have partnered with Ian and Alicia, and we work with the Colorado Comprehensive Cancer Control Program, to develop, again, I mentioned there's 2 years of data that we'll be presenting today on what we recognized as a need. So Ben comes to us with expertise in behavioral sleep medicine, especially in an oncology population. I've done a lot of program development and implementation, and so we kind of merge those skills together to develop educational programming for providers as well as for patients that we've offered to individuals across the state. So we'll be talking a bit about what is the problem. Oh, I guess agenda would probably be good on the next slide. So today we'll go through what is the need for sleep improvement and interventions in a cancer patient population and where are we at currently? How did we address the problem and create some opportunities in this issue? And then what were the outcomes of this program and where are we hoping to go from here? So we'll all learn a little bit about what cognitive behavioral therapy for insomnia is and how that intersects in an oncology patient population. And then we'll also talk a bit about, again, how we can potentially help you or patients across the state with sleep who have a cancer diagnosis.
Yeah, so I think it's really helpful to know the sort of research or clinical definition of insomnia. We throw this around, like, "Oh, I didn't sleep last night. I have such terrible insomnia." And there's the colloquial version and the research version are a bit different. So I think it's important to know because we're going to talk about some research findings that involve the real definition. So, as you know, insomnia is difficulty initiating or maintaining sleep. It has to bother you. You have to be dissatisfied with either quality or quantity, and it has to cause impairment. So, in multiple different environments like school, work, home, you have to experience it as a problem. And so, we like to say, like, you have to have kind of three symptoms of disruption. Like maybe your brain doesn't work that well because you're not sleeping. Maybe you're falling asleep when you shouldn't be, or maybe you can't really function because it's too hard to, you're getting sick because you're not sleeping. That would be three things. So we need three symptoms, and those are pretty varied, right? It impacts people differently. And then we need this problem to exist 3 nights per week for at least 3 months. So it's the rule of threes: three symptoms, 3 nights per week, 3 months, right? That's pretty hardcore. Now, if Erin and I waited around to treat our patients' sleep problems and we had to wait 3 months after they got steroids or started chemo, this would not be nice to them. And so most of what we do is actually treating sleep disruption that's not formally insomnia. And that's totally fine. I just wanted you to know the real definition. So we know that cancer patients have a pretty significant trouble sleeping. We also know that insomnia is pretty prevalent in the general population. So you can see that 12 to 25% of the normal population sometimes has insomnia, but 50 to 60% of cancer patients during their treatment or recovery have insomnia. And what we also know that I didn't put on the slide here is that cancer patients often have a run of bad sleep during their cancer treatment. And even if they're in survivorship and their cancer is not a current threat to them and they're not on treatment, insomnia that starts during cancer treatment often persists for years unless you do something about it. In fact, that's true of insomnia in general. I've worked with many, many patients who had an event 2, 3 years ago where their insomnia started, and it really has been a persistent force in their life since then. And we'll talk about how that's maintained and why that exists. As Erin and I have often talked about, nobody taught us this when we learned how to do the therapies for insomnia, so it was very hard to motivate people to do them. So we're going to teach you today a little bit about some of the underpinnings of how insomnia actually works. And I'll give you some of the very brief versions of, this is actually a 4-session class that we give for patients, and it's a 90-minute lecture we give to clinicians. We'll talk about that. So these are just picked and choosed from that sort of work that we have. We didn't have time to give you the full stack. Happy to send the full stack slides if you guys are curious, because you can sort of treat your own insomnia. Because our goal is just to help everybody sleep better. And then, of course, in certain populations in cancer, for instance, lung cancer patients, bone marrow transplant patients, people have really atrocious levels of insomnia that are pretty bad for most people. Lung cancer is actually the worst, but anyone who's had an allo transplant or has been in the hospital for a month knows that insomnia is a real part of the game. This is caused, of course, by complex interrelationships. Circadian disruption is a big part of it, inflammation, tumor growth, depression, anxiety, and pain, medication side effects. All of these contribute to that higher rate in cancer patients. So how do we treat insomnia? So in the general world, the American College of Physicians got together and unusual for them, recommended that all adult patients receive therapy for insomnia before a pill. So first line therapy, if you just have insomnia and you go to your primary care physician and you're like, I can't sleep, this is terrible, is not Ambien. It's not a pill. It is cognitive behavioral therapy for insomnia. It's not a tell me about your mother therapy. It is very much a behavioral therapy, and we'll walk through a couple of the components today. We have taken that and the straight normal stack of CBT-I, the eight or 10 sessions, is highly effective in oncology patients. It turns out it works great. In fact, it works so well. This is a meta-analysis of 8 studies with an N of 752. It showed very good. That's the average effect size of all those 8 studies. Some of the studies in this had effect sizes of like 2, like a Cohen's d of 2 something, which is really a big effect size. Like people were sleeping a lot better. And Erin and I, when we run the sleep class, we find that when we do this with folks, we do kind of a modified version that I really like. But they almost invariably, like 8 out of 9 or 9 out of 9 people in the group say that they really started sleeping a lot better by the end of the group. And we know from careful research that this is not just regression to the mean. It's not just that you had insomnia and it was bound to get better and that happened to happen during the class, so we can take credit for it. We know that with control groups, we can see these RCTs really do show that it's actually probably the most effective behavioral therapy for any problem that we have, like more effective than treatments for anxiety and depression and fatigue, are this therapy for insomnia. And for that reason, Erin and I, when we meet a patient that has insomnia and maybe anxiety and maybe depression, if their anxiety is not ragingly bad or depression is not the totally obvious like main problem, we start by treating insomnia because it actually is a transdiagnostic intervention. It makes the anxiety, it makes the depression better. I hope that makes sense. We've adapted this to have very short protocols, and it's a really nice sort of, forgive the metaphor, but like a teach you to fish therapy, where you go over this with your patient, you let them go run and practice it on their own, and then they know how to do it for a long time to come. So, like I was saying, we have this huge problem where we have a huge problem, like half of cancer patients have this problem, and we have a therapy, a treatment that works incredibly well, but nobody has access to it. It's a massive public health problem. And this is what I want to use my career in part to solve. It's a real big national problem, and it's a worldwide problem. So this is a nice study. It's a little old, by Sonia and Coley Israel, who's a famous circadian sleep researcher who's done a lot in cancer. She's very nice. She did this a while ago, and it's really telling, right? It shows the number of cancer patients out of a large number that have insomnia, and you can see that's the blue pie there, and it's a lot. And then the number that ever got any treatment at all for their insomnia. Um, and what you find is that they really don't. About 17% of people got treated. So José Savard, who's up in Quebec, did a really nice study and found that sleep is not routinely discussed in clinical practice, and that when treatments are offered, they tend to be pharmacological. People, the physicians and other people have a lot of barriers to getting people access to CBT-I. There's a lack of training in clinicians, and there's a lack of understanding about the efficacy of the therapy. People think because these pills have massive marketing budgets behind them that they must be more effective. And the truth is, they're really not at all. Um, a lot of that is the placebo effect. And it's not that Ambien doesn't work. We do have slides, we talk about medications a little bit, but they really have a lot of side effects also that are not desirable, particularly in an older cancer population. They're not things that we use. And Erin and I are not psychiatrists. That's not what we do. We don't have money from drug companies either. But everyone agrees. And actually, in the survivorship, the NCCN survivorship guidelines, CBT-I is listed also as the first line therapy. Um, yeah, so everyone agrees that this is the right thing. So doing CBT-I well is hard for cancer patients. They tend to bounce off it at first, and you have to really kind of sell it to them. Let me explain a little bit. This is what Erin and I teach patients, and I think it will be helpful for all of you to see the evolution of insomnia and kind of how it gets going and how it's maintained. So, folks with insomnia, we tend to be, I say we because I've had insomnia. That's how I got into this whole thing. I'm curious about it. we tend to be predisposed people, those who have insomnia. So we tend to be worriers or just alert or like have a lot of thoughts. And kind of like sometimes these are creative people. They're light sleepers. They're the people on the transatlantic flight or the flight to Hawaii where you're like wide awake. Maybe the flight back from Hawaii, where you're wide awake with your other light sleepers, but everybody else is knocked out and you're a little jealous. That's how you know you're in this club. And then they have a precipitating event, right? So the predisposed person has an event like a cancer diagnosis, medical cause. Maybe you have relationship trouble. Maybe you have stress. Maybe there's something going on that disrupted your sleep. In our world, that's also like the hospital or a course of steroids really like to mess up people's sleep. And for people that don't have insomnia and aren't predisposed, they just start sleeping normally after a few days. They probably rebound and catch up, and their sleep kind of automatically restores. But for people with insomnia, they develop, and it sets up very quickly, it can set up in a night or two, where they have these perpetuating factors. And so these include a lot of things that we've studied. Worry about sleep. You know, if you're worried about sleep, it's hard to sleep. Poor behaviors around sleep, right? People decide that they're going to go to bed at 8 o'clock and they normally go to bed at 10. And they're like, well, I'm really sleep deprived, so I better get lots of sleep tonight. And lo and behold, they lie awake and get stressed for 2 hours before they fall asleep. And that actually is part of the problem. Condition responses that prevent sleep. So this is actually the biggest factor, and it's one that nobody knows about, I don't think, outside of the sleep research world. I'm going to teach you more about that. Can anyone, we're going to do trivia now. I'm sorry to surprise you with trivia. I hope you weren't all eating your lunch or looking out the window because now you're going to have to answer a question. Can anyone tell me who this guy is? I will give you a hint. I always use this joke, Erin knows, but it is not the Santa from The Miracle on 34th Street, original version in black and white. But he is Russian. If you want to put your answer in the chat or just interrupt with a comment, that would be fun. I actually can't see the chat the way my screen. There we go. He loved dogs. He won the Nobel Prize. Does anybody have a guess now? I have two guesses. Yeah, there we go. Two correct guesses for Pavlov. So yes, this is Ivan Pavlov. He is famous and won the Nobel Prize for discovering classical conditioning. As you know, he trained dogs and measured their drool. I don't know how he got into doing this, but he found that when he gave the dogs meat and rang a bell at the same time, that they would drool, of course, and that he could take the meat away. And it was a great party trick to have the dogs still drool when he rang the bell. But this was a whole different kind of learning, and it's unconscious. It's not 2 + 2 = 4 learning. Something was going on in the body. And it turns out that when you spend those nights awake in bed, that the brain does something very similar to this, but with insomnia. So insomnia is maintained in large part by classical conditioning. Being awake, alert, frustrated, in pain, vigilant, or worried in bed pairs this with the place of sleep. And the brain essentially goes, oh, it's unsafe here. Let's never sleep here. It's a bad plan, right? And you can imagine if you entertain evolutionary biology arguments about why this sets up so easily and quickly in people. Like our ancestors in the plains of Africa, probably it's not a good idea to sleep where you've ever been attacked by a lion because they hunt at night. And that's not a great thing, right? And there's probably other examples from different parts of the world about why this was a terrible idea. And so the brain needs to really know that it's safe, and this sets up very quickly. We have to sleep. Without sleep, humans die fairly readily, but we also need to be safe. And so these circuits, even though we live in super comfortable mattresses with air conditioning and well-built houses where things are safer than they've ever been in human history, we still have this problem. So how do we fix it? So we fix this with there's 5 basic components to cognitive behavioral therapy for insomnia. We are not going to cover all of them, but I am going to teach you the most powerful one. And it's one that Erin and I, when we teach this in our class to our patients, they all get better about 2 weeks after we teach this. And it's very powerful and it's very easy, and it's called sleep compression. Let me walk through just so you understand. We do cover all of these in both the clinician class and the patient class that we run. Stimulus control is only sleeping in bed. I don't know why psychologists like to give everything a fancy name that sounds hard to understand, but the stimulus here is sleep. And we're going to control it by having you only sleep in bed. and try to limit any time where you might be awake in bed. And you can see immediately that that helps reduce classical conditioning. If we're cutting out time in bed where you would be awake or stressed or annoyed that you're awake, then obviously you're conditioning the bed as a place of just sleep, right? So that's easy. That makes sense. Functionally, Erin and I assign people a nest. We have them make a nest where they never sleep, where they do feel comfortable at night, where they can get up if they're having a bad night and do relaxation, and they go and sit there and relax. And if they get sleepy, they go get back in bed. That's what we do. Sleep restriction or compression, I'm going to explain in detail on the next slide, but that's limiting the total time in bed for sleep to near their total sleep time. So we just cut out extra time in bed. It turns out that's really effective. Cognitive therapy is targeting dysfunctional beliefs about sleep or sleep worry. We do cover this in all the classes. For some people, this is a big deal. I actually think it's about 10% of people. And I don't always use this when I treat people in my cancer clinic um, of their insomnia. I only break this out when really needed. And I think Erin does something similar. And then everybody likes relaxation techniques. These are important. I think a lot of us know how to do deep breathing, visual imaging, those kinds of things. We don't harp on those in the classes because most people know how to do them. In the patient class, Erin does a really amazing job of walking people through a couple of core cognitive and a couple of core ACT, acceptance and commitment therapy techniques for relaxation, and a cognitive diffusion exercise that I really like. And these are really helpful for reducing like psychic energy in the evening and helping people unwind. And then we do some sleep hygiene education. Everyone thinks that's so important, that all these rules about sleep and what to do and not do. And there is some value to that, but really the most effective components here, they're kind of in rank order. The behavioral ones are the most effective at the top. All right, so sleep compression. This is the slide we show clinicians. We use sleep journal data, right? So we have people check in and record how their sleep is. Functionally, Erin and I give them an app called CBT-I Coach that pings them every morning for free and just says, hey, have you filled out your sleep journal yet? Which helps tremendously with sort of throughput on the whole thing. It helps them be motivated. It reminds them they wanted to work on their sleep. And that app, if you want to download it, is totally free and developed by the VA, by sleep scientists at the VA, and it's great. It's not as beautiful as some of the more expensive apps, but it really works. And people like it, and it's free. So what we do is restrict time in bed to near total sleep time. And if you have, a person who's just a good historian, you can do this without waiting 2 weeks to get their data. And you can emphasize that they will not get less sleep, but only less time in bed. That's really important. Cancer patients are very defensive of their sleep time, and it's important for them to know that you're not trying to steal their sleep, just less time in bed. Cancer patients notoriously spend a ton of time in bed to sleep kind of not that much. You don't actually probably need that much more sleep if you're a cancer patient. But I have patients sleeping 12 hours or trying to 10 hours. And this is a setup for insomnia to get going and then be maintained. So we like to clear that out and then we let them expand back out and the sleep kind of magically follows. So maybe they were getting, here, let me show you. If you like pictures, this is another way to think about sleep compression. We take out their time awake in bed. So this person was going to bed at 9 and waking up at 9, which is not a healthy way to live your circadian rhythm. Nobody benefits from that. They shockingly were not sleeping that long. They were only sleeping about half of it, so 6 hours. And what we tell them to do is just compress it to like 6.5 hours and stay like that for a week to 3 weeks. And when they start sleeping reliably during that 6 hour chunk, when they start falling asleep firmly, kind of waking up right before, then we have them expand it out. And weirdly, because it cleared out the conditioning, their sleep follows and they can get back. If they were an 8 hour sleeper, they can get back much closer to 8 hours. And it works really well for people. It's amazing. If you do one thing to improve your sleep, this should probably be it. Now, it's hard to do. We have to explain about why, or people would never do this on their own. I had to realize why before I was motivated to try this for my insomnia. And you know what? It worked. But it's hard to do. And so we coach people and we coach clinicians on how to really motivate their patients to make these changes. And the app helps, right? There's a lot of ways. We now have these cool devices you can wear on your wrist that track your sleep. They're terrible at sleep staging, you should know that, but they are pretty good at overall duration. They're about the same as self-reported sleep, which is nice because it automatically does that. You don't have to think too much. All right. So I mentioned some of these things, but how can we improve behavioral therapy for sleep? So Erin and I wanted to take what we know about sleep interventions and consolidate it to only the most useful components for clinicians and for patients. And to do that, we decided to train clinicians because when you teach a clinician to do something different, you've helped hundreds of people, maybe thousands over the course of their career. If you get one clinician to start doing CBT-I with their patients, it's a very powerful forcing function. And in our next funding opportunity that we're looking at with CDPHE, we're going to focus really on doing that really well because it's a nice forcing function to really extend the intervention. We have a 4-session patient class that's done by Zoom that Erin and I run. We have remarkable, Erin will share with you some of the data, but it's really impressive. We make it oncology specific, right? This cannot be the normal stack CBT-I that you would get at a training or a class for people that have normal insomnia. Everything needs to be a little different and adjusted and more flexible for folks that have cancer. We add an area of research interest of mine is circadian biology, and we teach them about that. I haven't taught you much about that today. We don't have a whole lot of time, but I think it's really important. You kind of ignore circadian alignment at your peril, whether you're a cancer patient or not. And then we want to take, classic CBT-I was designed with this big overbuilt protocol, essentially to show great effect sizes on NIH R01s, which is not what works in clinic. So we wanted to consolidate it to the behavioral components mostly. And those have been tested independently, actually. What we're doing is exactly evidence-based. It's just a brief version. So that's called brief behavioral therapy. This is Wendy Troxell's stuff if you're curious to look it up. It's BBTI and it works quite well. And then we do a lot of tech stuff. That app is called CBT-I Coach. It's totally free. It's on both app stores. We have them downloaded at the beginning of the class. They start tracking their sleep. Then we help them maintain kind of a sleep prescription of new in bed and out of bed times that we actually custom prescribe for our patients in each class. Erin, do you want to
Sure.
take over here?
Yeah, that sounds great. So year one, which would have ended in July of 2025. So this was a lot of 2024 and 2025. What we were able to do was we developed a 1-session class that teaches these core components of CBTI in this brief format specific to an oncology patient population. And so that class was launched and we built the curriculum, recruited for that class from across the state. For that one in particular, we partnered very closely with Rocky Mountain Cancer Center, which has locations all throughout the state of Colorado. And their social work team was strongly encouraged to attend. And then we also had some oncologists, I think a pharmacist attended, and then some social workers. But the effort there was to get outside of Metro Colorado for year one, which we were successful in doing, or Metro Denver. And then for our sleep and cancer class, we had one just as proof of concept, essentially. So a 4-session class. We held our first class 4 consecutive weeks. And we taught them the brief behavioral principles for cognitive behavioral therapy. Week 1, talked about circadian rhythm, week 2, and then we had them or developed for them a personalized sleep prescription, which they then followed using the app if possible, or they could use pen and paper if they preferred. And then weeks 3 and 4, we talked a bit about the cognitive and psychological drivers potentially of their insomnia, as well as general stress in a cancer patient population and different strategies for managing that, including mindfulness-based stress reduction and relaxation, acceptance and commitment, and cognitive behavioral therapy techniques. And then continued to modify their personalized sleep prescription in those subsequent weeks. We did pre and post surveys for both of these groups, which then spit us out into year 2. But I think first for year 1, we'll look at where we recruited from. So we had 12 patients attend the class, 7 from RMCC, likely because of that close partnership with that first patient or provider training class. We had really high attendance throughout the course of the program, which is pretty unique. We usually see close to a 50% drop off for our sequential programming of different sorts. And so the fact that we had 8 of the 9 complete all 4 weeks, I think is a really good indicator that they felt it was useful and we're getting something out of the material. And then for our provider class, as I mentioned, we also had pretty high attendance given the registration, and a mix of different clinical backgrounds of people working with cancer patient populations. Um, and for all cohorts, for N equals 26, is that for, I cut this from the APOS poster, and so I'm forgetting if this was the patients or the providers, but it was year one. Um, so then for year two, what we decided was we looked at this, the feedback from the post-class surveys, and we decided to modify things a little bit. So we expanded who it is that we recruited. Also used our UC Health Network and CU Medicine Network to recruit for classes in year two, which I think might be on the next slide.
Yeah, and just sorry, I was muted when you asked that
Oh,
question before, Aaron. These were participants for the patient class. That's
oh,
what
great.
the map shows. Mhm.
Um, so and then we decided to double the offerings. We kind of had proof of concept. So we ended up running two provider classes, two patient classes, and we changed the curriculum a little bit. We do 2 weeks, a 1 week break, and then 2 weeks. So the 4 sessions take place over 5 weeks, because they get their personalized sleep prescription in week two. And we found that it just takes longer than a week for them to start noticing the changes. Um, and then they have been more successful in coming back and starting to see some improvement around that 2 week mark, which we can then carry through to weeks 4 and then 5 on a calendar. And then we also developed a novel alumni case consultation. So those providers that have attended any of our 3 trainings can come to a pop-in group, which we've held one of, and we'll have another one coming in June. Oh, and then we're also measuring the ISI, which you'll see in the subsequent slides here. It's the Insomnia Severity Index. So it's a standardized brief screening/diagnostic tool for insomnia, and basically how much it bothers and impacts you quality of life wise. So here is the map of our different cancer patients. So you can see we're starting to get a little bit into rural categories. For our provider class, we did have some up in Yampa Valley and some out on the western slope, kind of the Grand Junction area, but those are not mapped here. These are just for the patients. Again, good attendance, 28 registered, 24 attended. For the patient 2 classes, we had 24 registered, a pretty healthy mix between UC Health and RMCC. And then we had 2 patients withdrew from the class, and then overall 19 attended. So
Aaron, I
pretty,
want to make sure
yeah.
that the audience understands how remarkable this is. So normally when you run a psychology group, particularly by Zoom, for cancer patients, invariably somebody is throwing up or has to go to the hospital. And these folks like made pains to attend. I mean, the fact that we only had two withdraw out of 19 is really remarkable. They were really engaged. They were excited to be there. And each group we've run, they've gotten more excited and kind of gelled with each other in a really nice way. Particularly this last group was incredible. So I wanted to highlight, not to brag about our project, but that people really valued this class. It can be fairly dry and technical, and they really were engaged, which is fun. So yeah.
Yeah, I agree. It really seems like it's meeting a need that's quite unique in the cancer patient population. On the next slide, we wanted to go over some of our program outcomes. So unfortunately, these are not the most beautiful slides, but I cut and pasted this data. We used REDCap for our surveys. So out of all the provider classes that we've offered, so all 3, um, all that completed the post-class survey, which was 26, even though more attended the class, of course, we can't force them to complete the survey. They all indicated that the class quality was very good to excellent. And they all either agree to completely agree that their comfort in assessing and treating sleep problems improved. And this was just a one-time class. I think the first iteration we tried to do in 60 minutes, and then we expanded it the second and third iteration to 2 hours. It's just a little bit dense, and then it allowed more time for the participants to practice these skills. And then all agreed we used the feasibility intervention measure, and all agreed that it was feasible, possible, and easy to implement, and that this was something they could walk away and do in their clinical practice. And so here I just took a screenshot because visuals are nice. that their comfort in improving sleep problems in cancer patients improved as a result of this one session class. So it seems like it was effective in that aim. So for patients, we have a little bit more data that's also slightly more exciting. So again, we asked similarly what the quality of the program was, and they all said it was very good to excellent. They all agree to completely agree that the tools and interventions were feasible, easy to implement, so something that they could carry on their own. And 92% reported that their sleep improved as a result of attending this class. Again, we see that attrition. So even though we had a lot more people attend the class, on the patient side, only 12 completed the survey as of earlier this week. So we have a smaller sample there. But those that do fill the survey out seem to really feel like this intervention worked. And then we did the pre-post testing on that insomnia severity index. And so we saw improvements, which you'll see visually on these next slides, in falling asleep, staying asleep, and reduced frequency of waking up early from pre to post testing. And so you can see as we want things to be higher up on these scales visually. So it's the same question left and right. Left is pre, right is post. And so this is severity of their sleep difficulties. And so how often did they have difficulties falling asleep? And you can see everything started to trend, not necessarily upwards, but just towards the less severe degree, the way that the scale is presented. And so we had several individuals in the moderate, severe to very severe category on the left, and then no one in very severe, much smaller severe category, much smaller moderate category, and many more people in the mild to none difficulty with falling asleep as a result of this class. There's also improved sleep satisfaction. So you can see before they participated in the class, many individuals are very dissatisfied to dissatisfied with their sleep. And by completion of this class, they're less individuals dissatisfied, only two. Many more are moderately satisfied, and some are even satisfied with their sleep. So really seeing growth in positive directions out of the 13 individuals who filled that out. We're also noticing that they have reduced worry and distress about their sleep problems. And so on the left, you can see that this was very much a concern. They were very much worried or somewhat worried. And then on the right, again, we're trending downwards in the intensity of the worry and stress. And some people walked away not at all worried, and a good chunk were a little to somewhat. So just great improvement in quality of life and decrease in stress or distress as a result of participation. And then another good quality of life measure is to what extent do your sleep problems interfere with your ability to do your life, carry out chores, be the person you want to be in life, impact on mood, memory. So those who started to attend the class were noticing that it very much to much interfered with their daily life. And then again, we saw a nice bump, a reduction in severity to much, a good chunk or somewhat, and a little bit, a little. So it seems like in all these different approaches, this 4-session class was helpful for patients in their insomnia and quality of life. So for next steps, we are going to bring this class internal to UC Health starting in fall of 2026. We feel like we've got good proof of concept with the current public-facing iteration, which has been run through Zoom, and we're using some smart sheets for recruitment. And the problem with that is being outside of the MyChart or the Epic program, patients aren't reminded. And so it's just a lot of administrative work to remind them that the class is happening. There's potentially some issues with like patient communication going through email. And so this will move it into a secure platform. It allows the workflow we've already established for other groups and programs that we run to be followed here. And then patients will get those nice reminders that they get for other appointments through Epic. And then providers can also see that they've attended this class. So instead of having to take the onus on educating them on this material during their oncology visits, they can see that they've attended this class in their medical record, which will be nice. It also allows for improved financial support. We bill for our services. We don't have issues with insurance coverage, which is nice. So it also allows for financial sustainability of that class on the patient side. The area that has been mentioned earlier, we were most excited to see growth in is how can we get this information into more providers' hands and then impact sleep for cancer patients across the state as more providers are educated on the principles of CBT-I. And so our goal for this next year is to implement a statewide sleep champion project and to have people sign up to become a champion for sleep for their particular clinic or region. And we will help equip them not only with the materials for this class and train them in CBT-I, but also explore what community resources are available near where they practice. How can we implement these interventions in their clinic in particular? So the program will involve some leadership training, program development and implementation, as well as the good core concepts of CBT-I for the patients that they serve there. Our focus is on recruiting from rural communities. As we know, access to services, this is an example, can be harder outside of Metro Denver. And then given some of this data that we've had and the ease of implementation and strong feedback, we're looking over the course of the next year or two to publish what we've done under a QI effort, as this is not like IRB or consented research, but more of just a quality improvement project.
And Erin and I also have talked about matching. So we can actually we did group analysis, is what she showed you on the ISI data, and we can actually match person to person. So I think we can align like participant one's ISI with participants one's ISI at the end, and then do that for each one's and then calculate probably an effect size of the group, which would be really helpful. And yeah, we're excited to publish this. Are there we are happy to take questions about sleep problems, about things you'd like to learn about in regard to our program or about sleep. Would love to open it up for discussion. Somebody asked in chat, sorry if I missed this, does a patient survivor just sign up for this class? Yeah, is there a class that needs to be? No, this was a free class that we were offering. There are billing structures when we bring this in-house for the next version. But because this was generously funded by CDPHE, Erin and I had some protected time to do it, and we did not have to bill at all. So folks could sign up from any health system. Unfortunately, that's different now. They have to be a UC Health person. They don't necessarily have to have their cancer treatment at UC Health, but they do have to have an account with UC Health.
I think you mentioned at the outset that you have kind of a bigger deck that you can share. Is that right?
Yeah.
And would that be something we could share with our participants?
Yeah. Do you mean share with like patients of yours?
Well, we don't have patients. We're a nonprofit that has kind of healthy lifestyle programs for cancer survivors. And we provide some information to them, mostly about physical activity and a little bit about nutrition. But this would be a very helpful resource, it seems like. Help
Yeah.
get the word out if we can, obviously give you credit for all the work, but
Yeah. I would second that.
Yeah, I think we're happy to send the slides out. I would suggest it's hard the way we have them written to read them and interpret accurately what that slide was supposed to say, right? Like on the circadian slide, I have a picture of the Earth from the moon, and I know what to say on that slide, but I'm happy to send them and it'll give you a rough outline.
mhm.
But there's not like it's not like all texted out.
Or
Aaron and I
can,
might also be happy to you could refer people from your group, and we're happy to have you do that to the participant class, but also to the training if they work with patients in any context.
could would you be open to either dummying down that presentation that where the survivors could understand it, and or then one or two of you being participants on a podcast for survivorship?
So I think that latter idea would work really well. It would be a tremendous amount of work to take. I think we have a whole lot of slides, Aaron, to take all those concepts and write them out at a level that would hit sort of the average person's. It would just take a lot. It's much easier to explain it. And that's what we're kind of accustomed to. And we'd certainly be open to being on a podcast or recording a version with your organization at some point. It's all about time to do that. But I mean, we do have it all built. So
Okay.
Yeah, Ella had
And
a good point that the recording of this talk will be up on YouTube. So I think participants could be directed there. But I do think there's maybe some meaningful community engagement that we could explore. One thing that comes to mind is not like certainly we could come talk or we could be on a podcast and I don't think we could do the full class in that format, but we could say, hey, there's this thing that exists. But I also think maybe there's an opportunity for us to share email addresses because I'm sure you all have email addresses that you're disseminating. And so outside of CBT-I, we also have programming for stress reduction, body image after breast cancer, managing fears of recurrence, all sorts of classes under that like psychosocial cancer umbrella that we could open up. Like if you wanted to send that out to your participants, if it felt appropriate, and then they could call in and register for this and other classes as they are available in our system.
That'd be great.
you're welcome to shoot us an email. I think
Yeah, I'll put my email. Oh, there you go. It's
there
right
we
there.
are.
Just a kind of a personal question on the whole circadian rhythm thing. Had been having trouble sleeping myself and heard on some podcasts that I think maybe this guy's not 100% credible, but the idea of getting early morning sunlight, to stimulate your pineal gland, is that any part of your training here for folks? Because it seems to work for me.
Yeah, your experience is also a common one, and we do have it. They're called Zeitgebers or time givers is the technical term is Zeitgebers, and bright white light in the morning is the strongest one. It's better than taking melatonin in the evening. Melatonin actually is a little complicated, and you may need someone to help you find the right time. It's also not for everybody. It also doesn't work as well as bright white light. And in Colorado, we can just send people outside for a morning walk and problem solved. For my people from Seattle, or when I do these trainings nationally, like in New York, like we start talking about light boxes, right? And like what do you need? A lot of this light research is done in Scandinavia, where they have the problem already. But absolutely, that's the strongest one. There's other ones like not eating 3 hours before bedtime. The optimal timing of exercise is probably in the afternoon, but not right before bed. Also, in the morning is fine. If you exercise really first thing in the morning, it tends to pull your circadian rhythm a little earlier. And if you normally have trouble going to bed on time, that's probably a good thing. Um, yeah, and then there's having a consistent out of bed time is the other circadian marker that's really easy to hack. So yeah, we share that with our participants and also with the clinicians that we train as a fundamental core that we want all the body clocks lined up. You may know that we have the big clock up here. You reference the pineal gland, and the suprachiasmatic nucleus talks to that and tells it what to do. And it engages that timing system for the whole body. But we also have clocks in other subsystems in the body, and each cell actually has a clock. So there's about 36 trillion clocks in your body that time out the day length period for Earth, which I think is kind of amazing. So, because that's the number of cells in most humans. So yeah, we want when all those are lined up, not only does sleep get better, but a lot of other things also get better.
I had just a quick comment, but you just reminded me, Ben, of my great grandmother who moved. I think the story is she walked to Colorado with her family in 1906, and she lived to be 108 years old. And I got to live with her when I was young, and I remember she would wake up before the sun, but right, always like with the sun. So thank you for that reminder. But what I wanted to say was a lot of this discussion today. I'm a cancer survivor. Just reminded me that a lot of this is trauma informed too. When you talked about the safe spaces and just learning how to sleep again, it's I think it's really part of survivorship. So I'm really grateful for this discussion today, and I'm happy to share all this information with fellow survivors. So thank you.
Great. I'm glad you liked it, and thank you for sharing that story about your mom. That's incredible. Or it can't be your mom. That must have been. That's incredible.
This is my
So
great grandmother.
yes, thank you. Yeah, I mean, it's the trauma piece. I give my patients with psychological trauma like PTSD. I actually give them different instructions often because they do need sometimes like the TV on or background noise, something we wouldn't do for somebody that maybe doesn't have trauma. But I'm much more flexible. And then you're referencing the trauma of cancer, right? And taking back the bed as a place of rest and recovery and sleep when you've had to spend all this bad time in it. And that's absolutely the core of what we're doing. Yeah. Yeah. Thanks for the comment.
And again, you mentioned the pharmacological products, i.e. Ambien. What about those that are the plant material, the CBD, gummies of the world? Um, does that fit into the practice at all, or is that, again, sort of a taboo in your industry?
I think it was taboo from government research for so long that we don't know very much about it. I have a lot of referrals for insomnia to me in my clinic. I obviously treat all kinds of cancer problems, but but I have a higher stack of them, and a lot of them I'm like, well, they're like, well, I'm taking weed. I'm like, well, if it clearly isn't working, if and CBD is different than THC, and there's a bunch of compounds and there's a
Yeah.
bunch of different strains. There's a lot to know there. But no, I find that it doesn't really help everybody. Some patients get on one and they're like, this is the thing. It's without good research to guide us, it's really tough. You probably know this, but in studies of sleep medications, we do a double-blind placebo-controlled study, and the control group almost always has a massive impact. Like the sugar pill that they're taking that does absolutely nothing helps everyone sleep better immediately. And so it's important to like untangle that effect. If you're talking about, well, I started taking CBD and it really helped, you kind of want to know, like, if you took nothing and labeled it a pill or labeled it something, would it also work? Right. And so when it tends to fail those tests. But it may be that there's compounds within weed that really are effective. And some of my patients really swear it's the way they can unwind. A lot of it's about anxiety and like getting rid of that. So I'm not anti that. It's just we don't have great research yet. And it's being done. Like I have a colleague at Harvard who just does this, right? That Alana Braun just studies that. And she's a psychiatrist. She's doing an amazing work. So we will know these answers. They're coming. It's not that they're shunned.
Okay, thank you.
Other questions before we give you back maybe a little bit of time?
Thanks a lot. This was a great presentation.
Great.
Absolutely. This was excellent.
Thanks.
Thanks, everybody.
We appreciate the invitation.
Yeah, and happy to disseminate any resources that you have to people, even a tip sheet or links to podcasts, because it's such an important issue. And with that, have a wonderful, wonderful day. Thank you for your time and best wishes.
Thank you
Thanks.
very, very much.
Thanks, everybody.
Okay.